A Synoptic Pathology report for breast cancer. Welcome to the Everything Surgery podcast, where we dissect the extraordinary. Today, we are presenting a comprehensive, formal narrative of a Synoptic Pathology report for breast cancer. This episode is designed to help clinicians, students, and anyone interested in the details of breast cancer pathology understand the structure and significance of each component in a typical report. Patient and specimen overview. Let us begin with the patient and specimen information. Our patient is Jane Doe, who underwent a left breast lumpectomy with sentinel lymph node biopsy on the 5th of November, 2023. The specimen received was a segment of left breast tissue, and the procedure included a needle-localized partial mastectomy along with the removal of sentinel lymph nodes, under the care of Dr. Evans. Clinical history and diagnosis. This patient had an abnormality detected by a screening mammogram, which led to a biopsy. The biopsy revealed an invasive malignancy located in the upper outer quadrant of the left breast. The operation was performed to provide definitive therapy. Both preoperative and postoperative diagnosis confirmed a malignant neoplasm in the left breast. Macroscopic description. Upon gross examination, the breast specimen measured 6.5 by 5 by 4 centimeters. A cluster of 3 sentinel lymph nodes was submitted separately. The key finding was a firm, irregular, white mass with spiculated edges, measuring 1.8 centimeters at its largest dimension. This mass was situated 1.5 centimeters from the closest, or superior, surgical margin. A radio-opaque clip was also present within the lesion. All resection margins were marked with ink, and the superior margin appeared particularly close to the tumor on gross inspection. Microscopic findings. Microscopically, the tissue sections revealed an invasive carcinoma of no special type, commonly known as ductal carcinoma. The tumor was assigned a histological grade of 2 out of 3 based on the Nottingham grading system. This included moderate gland formation, moderate variation in nuclear size and shape, and a low mitotic count. The total score was 5 out of 9, corresponding to a moderate grade. Additionally, there was an associated ductal carcinoma in situ, which made up approximately 20% of the tumor area. This non-invasive component displayed both solid and cribriform patterns, was of intermediate grade, and showed areas of comedotype cell death. Importantly, there was no evidence of invasion into blood vessels or lymphatics. In terms of surgical margins, the invasive cancer was as close as 0.1 centimeters to the superior margin, while the ductal carcinoma in situ extended to less than 0.05 centimeters from this same edge. All other margins were clear by more than half a centimeter. The sentinel lymph nodes, 3 in total, showed no evidence of metastatic cancer or isolated tumor cells, resulting in a staging designation of PN0 with no isolated tumor cells. There was no treatment-related effect noted, as the patient had not received any preoperative therapy. Immunohistochemical profile. Special staining techniques were applied to the invasive cancer. The tumor cell showed strong, diffuse nuclear staining for estrogen receptors in 95% of cells, and moderate nuclear staining for progesterone receptors in 60% of cells. The test for the human epidermal growth factor receptor 2 protein was negative, with only faint, incomplete staining. As such, further testing for gene amplification was not indicated. The proliferation rate, as measured by the Ki67 marker, was approximately 18%. Synoptic summary. In summary, this case is an invasive ductal carcinoma with an associated non-invasive component. The invasive portion measured 1.8 centimeters and was graded as moderately differentiated. Ductal carcinoma in situ was present, intermediate in grade, and showed comedotype cell death. There was no evidence of cancer cells in the lymphatic system or blood vessels. The closest margin for invasive cancer was the superior margin at 0.1 centimeters, and for ductal carcinoma in situ, less than 0.05 centimeters. None of the 3 sentinel lymph nodes contained metastatic disease, resulting in a pathological stage of PT1C, PN0, CM0, which corresponds to stage 1A breast cancer. The biomarker profile was positive for hormone receptors and negative for human epidermal growth factor receptor 2, with a moderate proliferation index. Explanation of key components. Now, let us break down the significance of each section of this report. The histologic type, invasive carcinoma of no special type, is the most common form of breast cancer. The Nottingham grading system evaluates how abnormal the cancer cells appear and how quickly they are likely to grow and spread. A grade of 2 means the tumor is moderately aggressive. Tumor size is an important factor in staging. In this example, 1.8 centimeters places the tumor in the PT1C category. Lymph node status is another powerful prognostic factor. No evidence of spread to the 3 sentinel lymph nodes is a favorable finding. Surgical margins tell us whether cancer has been completely removed. A positive margin means cancer cells are found at the edge of the tissue, often requiring further surgery. A close margin, as seen here, is borderline and may prompt additional treatment based on clinical circumstances. Negative margins confirm complete excision. Biomarker studies are essential for guiding therapy. Positive estrogen and progesterone receptor status means the tumor's growth is hormone-driven, making hormone therapy an effective option. A negative human epidermal growth factor receptor 2 status indicates that therapies targeting this protein are not needed. The Ki-67 index reflects how quickly the cancer cells are dividing, with higher levels suggesting a more aggressive tumor. Finally, when we combine these biomarker results, we can classify the tumor's intrinsic subtype. Based on this profile, positive for estrogen and progesterone receptors, negative for human epidermal growth factor receptor 2, and a moderate proliferation rate, this cancer falls into the luminal B-like category. These tumors may require both hormone therapy and chemotherapy, reflecting a more tailored, personalized treatment approach in modern oncology. Thank you for joining us for this expert walkthrough of a breast cancer synoptic pathology report. If you found this discussion helpful, please like, share, and subscribe to the Everything Surgery podcast for more deep dives into surgical pathology and clinical practice. Until next time, keep learning and stay curious.